Good morning, good afternoon, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I am a registered dietitian on the medical and scientific affairs team with VitaFlow North America. We're excited to bring you this educational activity and introduce today's speakers. Our topic is risks and disadvantages of decanting enteral nutrition formula in pediatric kidney disease. Please note this program is being recorded. Support for this program was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note, questions will be addressed following the presentation. However, you are welcome to submit text questions into the Q&A pane at any time during the program. You can access a PDF of the slides using the link Presentation Slides. This program is not eligible for CPE credit. Now, I have the pleasure of introducing our speakers today. Alicia Pavlik is a registered dietitian and board-certified specialist in pediatric nutrition. Alicia currently serves as an account development specialist at VitaFlow North America. With over 15 years of clinical experience, she has specialized in medical nutrition therapy for pediatric nephrology patients at the Children's Hospital of Philadelphia for 13 of these years. Prior to her current role, she was a clinical liaison with Aviana. Beyond her clinical expertise, Alicia is a published author, sought-after speaker, and consultant. She has presented at numerous local and international professional conferences, delivering lectures, webcasts, and educational workshops. Above all, she is the proud mother of William, who is 8, Jack, who is 6, and Benjamin. Jessamine Newcomb is a registered dietitian who has been at New York Presbyterian Morgan Stanley Children's Hospital for 8 years, primarily working with pediatric CKD, dialysis, and transplant. She earned her bachelor's degree in dietetics at the University of Delaware. Jessamine has been an invited speaker presenting on topics such as CKD and pediatric nutrition and pediatric transplant nutrition. In her free time, she likes to cook and spend time with her dog, Dylan. With that, I would like to hand it over to Alicia.
Thanks so much, Michelle. I'm really happy to be here today talking about this important topic. So we're going to start by defining decanting, what it is, why it's something used in medical nutrition therapy. Then we'll discuss the risks like unintended nutrient changes, electrolyte imbalances, and serious safety concerns. We'll describe the burden it places on caregivers and hospital personnel. And lastly, we'll encourage critical thinking about whether safer, more effective alternatives are available. So decanting is a practice where binders like sodium polystyrene sulfonate, SPS, or sevelamer, which are usually given directly to a patient, are instead used to treat human milk or formula. And we're going to talk more about these medications in detail in the subsequent slides. The goal of this practice is to lower potassium or phosphorus levels in feeds. It's often used for children with chronic kidney disease, CKD, or acute kidney injury, AKI, who may have difficulty clearing these minerals. While the intent is to make feeds safer, we'll discuss why this process is not without risks and needs careful evaluation. So decanting became a tool because historically there were limited renal formula options for children. It was a method to help manage hyperkalemia and hyperphosphatemia, and clinicians aim to create a more kidney-friendly nutrient profile by altering available formulas. So we decant by adding an extra 200 mLs of formula to a 24-hour supply. This compensates to the formula that will be discarded at the end of the process with the binder. Then the binder is directly added to the 24-hour batch. It's vigorously shaken so the mixture is dispersed evenly throughout the formula, and then placed in the refrigerator for the appropriate time based on the medication that you're using to decant. This allows time for the binder to interact with the electrolytes. Lastly, after refrigeration, you want to carefully pour most of the formula into a new container, leaving behind the sediment. And in this slide where that blue arrow is, that highlights the sediment, and the goal is to keep that sediment in your original container. The sediment contains the binder and the electrolytes it's removed, and then you have your decanted feed, and that is what is going to be provided to the patient. So now let's talk about managing hyperphosphatemia. Sevelamer is a phosphorus binder, sometimes used in decanting to reduce the phosphorus content of feeds. We'll review key publications by Ferreira, Raha Makers, and Taylor examining the risks, efficacy, and nutrient impact of this practice. These studies raise important questions about the safety, consistency, and practicality of using sevelamer in decanting. This slide shows the different dosages of sevelamer used for decanting across our key studies. And I want to draw particular attention to the dose used by Taylor. He showed that when decanting Ciplena, a very high dose of sevelamer was needed to achieve a significant reduction in phosphorus. In Taylor's study, 3,200 milligrams of sevelamer was needed. This is equivalent to 4 800 milligram packets, and I have that illustrated across the top of the slide. So that's your 4 packets. And this large amount of medication was added to only 100 mLs, or a little over 3 ounces of formula. And to put this into context, a full 24-hour feed often requires about 800 mLs or more of formula. So this means if you extrapolate that dosing, you'll need an extremely large amount of binders relative to the total volume of feed. So that's kind of our intro to sevelamer and the studies we're going to look at. And now we'll shift gears to managing hyperkalemia. The Pediatric Renal Nutrition Task Force has a nice outline on how to manage hyperkalemia. And it looks much better when it's not on this busy slide. So the reference is here on the left, and the publication is free to access. So we can all stop trying to read this busy slide. And I can tell you in summary, the recommendation is to start by addressing the non-dietary causes of hyperkalemia, then restricting the potassium content of a feed, and as a last resort, using a binder medication. And a binder medication example is SPS. So SPS is a potassium binding resident. It works through sodium-base cation exchange, replacing potassium ions with sodium ions. It's important to note that SPS carries an FDA black box warning for risk of intestinal necrosis. And in this talk, we're going to focus on 3 key publications that describe decanting with SPS. As a common rule of thumb, the dose is approximately 0.5 grams of SPS per 1 milliequivalent of potassium in the feed. And also detailed in this slide are our key studies and the wide variety of dosing used in the papers, and starts to reflect the lack of standardized practice that we see in decanting. So that is SPS. And another potassium binder that's used is patiromer. So instead of a sodium-based cation exchange like SPS, patiromer is a calcium-based exchange, replacing potassium ions with calcium ions. Polonia concluded that a dose of about 16.8 grams per 500 mLs was a dose that yielded a desirable result, but they did look at a variety of doses. So now we kind of talked about what decanting is, why we do it, how we do it, and the medications and the doses that are used. And we're going to go into the risks and challenges. So decanting with sevelamer alters the nutrient profile of feeds, impacting more than just the targeted phosphorus. And all three of our key studies, they observed what they wanted to do, which was decrease the phosphorus content. But also, all of the studies demonstrated a decrease in calcium. And I want to draw your attention to the calcium that Raha makers saw. They reported a notable 75% reduction in calcium in treated expressed human milk and cited this as a potential clinical concern. Also notably, Ferreira shows a 14% decrease in protein, and Taylor's high dose of sevelamer needed for phosphorus reduction in Suplena also led to broad nutrient changes. And importantly, Taylor concludes that the large dose required for pre-treating sevelamer for pre-treating Suplena with Suplena is ill-advised, and I would agree with that. That's a very large dose for a small amount of formula to get any kind of efficacy. And our clinical takeaway from these three key papers and these tables is that while phosphorus binding is achieved, unintended nutrient depletion, especially calcium, is also a consequence. So Taylor's paper demonstrates not only does sevelamer alter the nutrient profiles, but SPS does as well. The table on the left shows the nutrients that decreased, and the right shows the nutrients that were increased. So SPS is that sodium-based exchange, replacing potassium with sodium. And this exchange is reflective in the changes in the nutrient profile. Potassium went down, sodium went up. And there's sometimes a question if decanting changes the taste of a feed. And in my opinion, I think it's reasonable to assume that if a greater than 200% increase in sodium would certainly alter the taste of a feed. Additionally, these variable nutrient alterations can affect the effectiveness, the safety of other supplements and medications commonly used in pediatric kidney disease. So our takeaway is decanting with SPS doesn't just remove potassium. It also alters essential nutrients like calcium, iron, and sodium, introducing new risks that must be carefully considered. So Taylor also found that pre-treating both formulas with SPS caused marked increases in aluminum ranging from 500 to 4,000%. This is highly concerning in pediatric CKD, where aluminum excretion is impaired and leads to a risk of aluminum accumulation. So elevated aluminum levels in CKD can contribute to serious complications, including neurotoxicity, poor bone mineralization, anemia, and growth delays. So decanting with SPS may introduce harmful levels of aluminum, posing a significant safety risk for children with CKD. So now we've seen that decanting with sevelamer and SPS cause unintended nutrient alterations. So what about our other binder, patiromer? Polonia shows us that patiromer does as well. So patiromer is a calcium-based exchange, replacing potassium with calcium. And again, this exchange is reflective in the change in the nutrient profile. The potassium went down and the calcium went up. However, an unintended consequence of increasing phosphorus levels was also observed. And this phosphorus rise is clinically important because many children who are requiring a decanted feed for hyperkalemia are also at risk for hyperphosphatemia because of their underlying kidney disease. And increasing the phosphorus content could worsen mineral and bone disorders. So even when achieving the intended potassium and calcium shifts, patiromer decanting still alters the nutrient profile in other concerning ways. So I recently had the awesome experience of talking with a group of clinicians at the National Kidney Foundation meeting, and we were talking about decanting, and the topic of the double decant came up. And double decanting is when you're treating a feed with both a potassium and a phosphorus binder. And two of the clinicians mentioned that they currently have patients on the double decanted feeds. And so I asked, I was like, well, how do their labs look? And unfortunately, they both responded by saying they're terrible. And this does mirror what Taylor demonstrates in his publication. Taylor's study found that pre-treating Suplena with both SPS and sevelamer did not significantly reduce potassium or phosphorus content. It made both the binders ineffective. And despite no meaningful binding of the targeted electrolytes, there was still a significant alteration in other critical nutrients. So double decanting not only fails to deliver its intended goal of reducing potassium and phosphorus, it may actually worsen clinical outcomes by destabilizing the nutrient profile. So we just reviewed how decanting alters the nutrient composition of feeds. So now let's look at two studies that evaluate the clinical impact, specifically the alterations in serum electrolytes of patients receiving feeds decanted with SPS. So in Palma's study, more than 50% of treatment courses resulted in at least one serum electrolyte abnormality. 26% hypernatremia, 32% hypokalemia, and 21% hypocalcemia. Thompson observed a 24% decrease in serum potassium levels, but also noted a significant decrease in serum calcium. So these findings highlight that decanting doesn't just change the formula, it can lead to clinically significant electrolyte disturbances, really reinforcing the need for caution and close monitoring. So we saw in the previous slide that Krisha Palma, Dr. Larry Koplovich, and I saw in our published analysis that more than 50% of the decanting courses resulted in at least one electrolyte abnormality. Additionally, 2 patients experienced potentially life-threatening complications. So in case 1, the toddler presented with severe hypokalemia. His serum potassium was down to 1.7, and severe hypocalcemia with his serum calcium all the way down to 4.8. He required hospitalization and careful intravenous electrolyte repletion. And then in case 2, the baby developed bowel necrosis. That was a catastrophic gastrointestinal event that ultimately led to the withdrawal of care. Autopsy revealed a hernia and crystals of SPS in the bowel, raising concern for SPS-associated injury. I've heard that you remember the patients more that you didn't help than the ones that you did. And this is true for me. These events sit heavy. And if you leave with one takeaway today, please let it be this, that these cases illustrate that decanting is not a benign practice. It has the potential to cause severe and irreversible harm, and we must really critically evaluate the safety of using decanting and seek safer alternatives whenever possible. So decanting is also burdensome for caregivers and clinical teams. It takes time, requires precision, and increases the chance of human error during feed preparation. It adds layers of complexity to both home and hospital feeding routines, making consistency even more difficult. And this process increases the workload for nurses, formula room staff, pharmacy, impacting what we already know are stretched resources. Decanting also raises the risk of contamination, which is a serious concern in these medically fragile patients. Decanting is not a validated or regulated process. There's no standardized method to ensure safety or consistency. So in summary, decanting is problematic because it leads to unintended nutrient changes, causes electrolyte imbalances, carries serious safety concern, and adds burden to caregivers and staff. Decanting is not a neutral intervention. It carries real risks, and clinicians really should critically evaluate its use and consider safer alternatives whenever possible. This slide is a new handout and resource available to you from VitaFlow through your strategic account manager that we hope is a helpful tool in these continued conversations about decanting. So now let's move on to talking about some safer alternatives.
Could I interrupt you?
Yes, please.
We are getting some really good clinical questions. So before we move on to alternatives,
Right.
we have a question from Sarah. If using SPS to pre-treat formula, how often do you recommend checking aluminum, zinc, and other micronutrients that are not routinely checked in children with end-stage renal disease?
That's a great question. And my recommendation would be if you're initiating this process to get a baseline, and you're probably going to be checking labs in the outpatient setting every few days, and certainly daily, if not at least twice a day in the inpatient setting, until you achieve some kind of consistency or some kind of electrolyte balance. So baseline, and then upfront quite a bit of lab checks. And then kind of once you hit a steady state, if you do hit a steady state, I would recommend checking those labs every 1 to 3 months. That would probably be, I think, a reasonable interval to check those non-routine labs when you're doing these practices.
Thank you. One more. This is from Anonymous. Why do you think that phosphorus levels increased when the formula was decanted with patiромere? I always thought the extra calcium going into the solution may help to bind some phosphorus so the finding in the study you presented is very interesting.
It is, and there has to be some kind of exchange that happens, and the paper does go in more detail of it, and I can read it and follow up, but there must have been some kind of phosphorus in the preparation or the medication itself that shifted into the feed once the decanting process happened. But I agree, you would think if you put more calcium in, that would bind the phosphorus.
Sarah says thank you. That's it for now. Thank you.
Awesome. Sure. Thanks for the great questions. And talking about our safer alternatives, there are only 2 formulas in the US specifically designed to meet the needs of children with kidney disease. And as a clinician, I found these products incredibly helpful. I was able to titrate formula composition based on each patient's unique electrolyte tolerance, something that's not possible with decanting. And unlike decanting, which causes unintended alterations in nutrients, these products are formulated to deliver consistency and safety. They eliminate the need for complex decanting steps and simplify workflow for caregivers, parents, and our stretched clinical staff. These products allow alignment with best practice recommendations and the guidelines, such as the Pediatric Nutrition Task Force approach to the management of hyperkalemia. RenaStart and RenaStep are purposefully incomplete. We're not going to give the DRI or the SDI for potassium and phosphorus when we clearly demonstrated we're trying to do all of these interventions to decrease that, because that electrolyte tolerance isn't there for patients with kidney disease. So they're selectively restricted in renal specific nutrients. Notably, and very applicable to this talk, in both potassium and phosphorus. So the key points are that RenaStart and RenaStep are nutritionally complete, except for the targeted renal restrictions. So let's talk about CKD and hydrolyzed formula. So CKD presents very complex feeding challenges. Uremia, delayed gastric emptying, nausea, vomiting, and reflux are all common. And these factors often drive hydrolyzed formula use, not necessarily a true milk protein allergy. And in my opinion, these patients really deserve a thorough workup before committing them to long-term hydrolyzed formula use. I'm not saying it isn't always necessary, but I do think that doing due diligence is advantageous. And if a hypoallergenic feeding is truly necessary, my recommendation would be to use a hydrolyzed base and then customize with hypoallergenic modulars like fat and carbohydrate powders, oil emulsions, amino acid mixes, with the ultimate goal of a low electrolyte hypoallergenic formula tailored to the individual patient. So wrapping up here with some best practices. Really avoiding decanting whenever possible due to the safety and inconsistency. You want to use those renal specific formulas like RenaStart and RenaStep, customize, tailor the formula to meet the unique needs, monitor labs closely, and then supplement intentionally. And I have here for you all of my resources as a reference for you. And I am going to hand it over to Jessamine for a case study.
Hi. Thank you for having me. So we'll start with the case study. It's one of my patients. Name is GR. He was 3 months old when he kind of came to our facility. For his past medical history, he had Eagle-Barrett syndrome, or also known as prune belly. He had bilateral hydronephrosis. Oh, let me put the slide over. Sorry. Bilateral hydronephrosis, non-functioning left kidney, a neurogenic bladder on clean intermittent cath, and CKD4. With the Eagle-Barrett and all the urinary tract abnormalities, the goal is to preserve bladder and kidney drainage and function and to prevent any UTIs. And as a dietitian and a nutrition standpoint, our concerns were really electrolyte abnormalities, poor growth, oral aversions, and things like that. For medications, he was on calcium, vitamin D, iron, Bisotra, and some sodium supplements. For his diet, he was on Similac PM 60/40 to 20 calories per ounce. When he was in a NICU, before we met him, he had really bad electrolyte abnormalities. So he was either on breast milk and then Similac PM 60/40 when breast milk was not available. And he was taking about 24 fluid ounces a day at that time. GI, he was having 2 to 4 loose stools a day, and then he was having some vomiting with the Bisotra. So just wanted to go over a few visits that kind of led up to a lot of the decision making. So his first visit, when we met him, he was admitted for COVID and UTI. This was like, I think, April 2020. He had decreased PO for a week prior to admission. He came in, his labs were potassium 5.6, CO2 was 20, so that was a little bit low, and everything else was kind of reasonable. Something to know is that compared to birth, his growth has really declined. So he had a decline of 3 weight for age and weight for length Z-scores at this point. And if you average out his growth, he was gaining about 17.2 grams per day. So the plan was to decant the Similac PM 60/40 with K-Exolate, and he was discharged home. During this admission, the parents were educated on decanting the formula. And as Alicia said, decanting just really puts stress on like the staff members, nursing, and also family members. So something to keep in mind when you're doing this as an intervention. In our facility particularly, the responsibility of decanting isn't, we don't have a policy, so it doesn't live with one department. So it's either family at bedside or nursing that does it. But it's not like nursing must do it every decanting feed. And then next visit, he was 4 months old. He was still on the decanted Similac PM 60/40. He was taking about 113 calories per gram from formula, which is pretty good compared to what he would ideally take, like a DRI for age. Labs were okay. K was 4.4. Again, his growth has been really poor. He was gaining 11 grams per day over the past month. And then now he's also declined Z-score and 1 length for age. There were no GI issues reported. And given the poor growth, the plan was to go up on the calorie concentration. Fast forward, he's now 10 months on visit number 3. He's taking some purees up to 5 times per day, mostly lower potassium purees. He was doing like carrots and peas and chicken and rice purees. Labs were okay. K was 4.9, but again, CO2 was 18, just because he was still having issues tolerating the Bisotra. And again, for growth, he still declined 3 Z-scores since birth, and his grams per day growth has been okay-ish, but not enough to, get some catch-up growth. And then at that point, the plan was to trial a higher concentration formula just to see if he can grow just a little bit better. All right, so 4 months old is when I met him. At this point, he was on Similac PM 60/40 to 32 calories per ounce. Based on what parents were reporting, this came out to like 115 calories per kilo, which is a pretty good amount for his weight. Solids, he was still having a lot of feeding difficulties, oral aversion, was really poor intake of that, mostly formula fed, and we were awaiting feeding therapy. As far as growth, it's still pretty low. For his age, he was gaining about 2.5 grams per day for the past like 3.5 months. So that's really below his expected. And then since birth, he still continues to decline pretty significantly. We're talking to mom, seeing what's going on, really worried about growth and, maybe thinking about, do we need to admit this child? And she tells us like, oh, he's been having diarrhea since we started decanting with Caxlate, more than 6 months ago. And then he was also having ongoing vomiting with the Bicitra. So at this point, the plan was, we've tried so many things already. He's having GI problems with the Caxlate. He's vomiting from the medication. So we were saying, we've trialed this formula and this plan long enough. And we had Renastep as an available option. So gave him some samples. We didn't make any like strict changes that visit because the labs were stable. The potassium was fine. And then the doctor also sent a GI referral for a G2 placement. Let's see. So we see him again. He's now 23 months at visit 5. He's taking about 3 bottles per day of Renastep. It comes out about 120 calories per kilo. He is still waiting feeding therapy, ongoing like oral version. He's really not doing well with eating, but mom did report that he seems at least more interested in foods and like wanting to play and touch it and things like that. So at least there was some improvement from that end, but we still wanted him to get extensive feeding therapy and be evaluated. What I think is exciting is since the last visit, so the past 3 months, he's gained about 12.4 grams per day. So around that age, the expected is 4 to 9 grams. So he's doing way above what we expected, which is appropriate for some catch-up growth. And he's also gaining some linear growth, which is really nice. And then, he increased by 1 length for age, and then the weight for length also increased by 1. By the time he's on the Renastep only, he's had no diarrhea with the current feeding regimen. He actually needed Miralax starting 2 months in because he was having some constipation. He is still having some vomiting with the medications, but it's improving. He really wasn't vomiting that much daily. So all things were really improving for him. And then I just kind of want to show you his growth curve. Hindsight is 2020, but when I was looking at this, I was like, ooh, there's a lot of points where we probably could have trialed something a little more like admit him or something like that to really get to the root problem. But you can kind of see like, at 3 months, he was like doing okay. And he really dropped off the curve. And I showed the arrow where we trialed the Renastep. So the green arrow was before, and then he really went back up on the curve just 3 months after switching to formula, not having diarrhea. So that was really nice to see an improvement, not just in growth, but also like just GI symptoms in general. And so in summary, some takeaways, think about switching formulas if you're having some GI issues on decanted formula. Also compliance and caregiver burden, as Alicia mentioned, with decanting. If you notice, there was some big jumps with his calorie concentration. Sometimes, we've seen parents like, oh, I added a scoop of formula because I feel like he wasn't gaining that much weight, which could be, it could be a little dangerous when you're decanting because you're dosing your Caxlate based on like what the recipe is. So keeping that in mind. And then again, like the altered taste of decanted formulas, not with this patient specifically, but I've had other parents who tasted decanted formulas and they have said that like, oh, it tastes very different than like what it was before. One parent said it was definitely saltier than just a regular Similac PM. And so where is GR now? So he did get the G2 place like a month after that visit. He's still doing well on the Renastep overnight feeds. He's not having any GI issues. He's currently waiting for a kidney transplant. We're hoping sometimes this year. And then he's had stable weight and linear growth. He's hanging on the growth curve and, judging along. And that's it. Thank you.
Oh, thank you, Jessamine. We have a comment. It's not a question, and I just want to share it before Jessamine goes off screen. This is from Anonymous. In cases like this, I often use a combination of Similac PM 6040 and Renastart, which provides sufficient calories and helps control potassium. So someone just wanted to share their experience. Okay, thank you, Jessamine. I'm going to talk a little bit about changes coming down the pike to Renastart. So our strategic account managers are out and they are really trying to talk to everyone and update people on these changes. We also sent out an e-blast communication detailing our changes. So the big change is the place of manufacture has changed, which then in turn has affected the product formulation. So really, they're not significant changes. They shouldn't result in a change in product use. And then we want you to know the whole team is really here to help you if you have any questions. So please feel free to reach out. Production has been transferred to a Nestle facility in Switzerland, and this will ensure the capacity to support the continued growth of Renastart globally. So it's really for continuity of supply. And, it's really frightening to think of supply shortages. We've seen formula shortages. So we're all really proud of this change and happy it's occurring. Okay, so what does it mean to the formulation? Again, it's minimal changes. What we really want you to know, the changes in sources of ingredients are to match those already used in similar powdered products, which are already manufactured at the new plant. So you get economies of scale. We want to use very high quality products, but if you're using what they have, you can, save money, which we feel is important. And then we still want to ensure optimum quality in the finished product. So a big change is the emulsifier has been replaced by soy lecithin. So now this requires a new soy allergen, and it's due to the soy lecithin. There's not really consensus on restricting this ingredient in children with soy allergies. So some dietitians will absolutely do it because we don't know. There are definitely trace residues of protein in soy lecithin. There have been some case reports of kids with very severe allergies having reactions, but then a lot of people don't restrict it. They feel it's fine and it's due to the very, very small amounts. But for us, we have to declare it on the packaging. And this can definitely cause some concern with caregivers. So, we may need to talk to our patient families about this. Good news, though, we do like to offer choices. So Renastep still does not have soy listed as an allergen. Renastep does not contain soy lecithin. So the updated Renastart continues to contain milk protein. We have this new allergen, and the allergen statement will be clearly displayed on the outer box. And then just again, case by case, looking at your patients. Okay, so this is some very nice stuff. Whenever you change a product, there's always that transition phase. So the new product is hitting market, but then you're still going to see a lot of it still out there. Families have it. So our marketing team deliberately changed the appearance of the can. So at the bottom, we had this straight green band. Now it's more of an arch. So it will be very obvious if you have the new or the old version. Really good news. The scoop is remaining the same, weighing out approximately 7 grams of powder. So just looking at some of the differences in the nutrients, these really aren't great changes. Most of the nutrients are going up slightly, but if I could have you look at the 100-gram column, so the calories are changing from 494 to 496. So that is a 2-calorie change per 100 grams. And then things like vitamin C. It used to be 65 milligrams at almost 500 calories. It is now going to be 60 milligrams at almost 500 calories. And that's one of the exceptions where it's going down, not up. Looking at things like sodium, it used to be 210 milligrams per almost 500 calories. Now we're at 240. So our team does have these type of materials to share with you. Please, again, just reach out. Patient caregivers are very astute with noticing changes in formula. So we want to also let you know that the color is going to be a little different. The updated Renastart powder is a little bit more yellow compared to the current Renastart powder, which is a little bit more white. And then we did sensory testing, looking at the current and the updated, and they really showed little difference in terms of solubility and taste preference. There is going to be a different product number. So you'll see that right here, and then different item number. So that is going to be important. Again, you have access to these slides. If you look at the webinar, there is a little link below. It says presentation for the slides. With that, I want to thank you. We have received a ton of questions and we have plenty of time to answer these questions. So I'd like to invite Alicia and Jessamine back up. And Alicia, some of these you and I could certainly answer together. I'm going to direct them to you, but feel free to turf it back my way too for medical affairs.
Sounds great.
So I'm going to start out with anonymous. So I will direct this to Alicia. Is there a difference in adequacy of binders, sevelamer, for decanting inorganic versus organic phosphorus?
No, I can't recall, and I'm trying to go through the studies now to see if they addressed any of that, and I can't recall if they did or not. And I don't know, Justin, does anybody else know? Do you know, Justin? I don't know if there was ever a.
I've never even thought of this question.
Right. Yeah. So not to my knowledge, is there a difference in the binding capacity for an organic versus an inorganic phosphorus? The absorption of inorganic phosphorus is exponentially higher than an organic phosphorus, but I'm not sure about the binding capacity from a medication.
Great, thank you. Okay, this is from Sarah. This is a multi-part question. Does sevelamer need to be mixed into the formula in order to work in a tube feeder? Or can they just add sevelamer to the G-tube and it will get mixed into the feed in the stomach?
That was after looking at this literature. My recommendation was, if you're utilizing sevelamer as a phosphorus binder, to instead give it to the patient and utilize the binding capacity in the GI tract as the medication was intended to be used to do. And I would get questions a lot about, well, what if it is a continuous feed? And my recommendation to that would be just take your total dose and dose it Q3 or Q4 to get that binding capacity in the gastrointestinal tract and avoid decanting.
Thank you. Okay, this is from Julie. I have heard using a fiber-containing formula for decanting is ineffective and patients consume more SPS because it doesn't create a good sludge. Is there anything mentioned about this?
There is in Taylor's paper. They kind of hypothesize why, especially Suplena, wasn't effective with binding. So it may be the fiber content as a contributing factor. That would make it variable And as we showed, there's quite a bit of variability depending upon what you're trying to decant.
Great, thank you. Okay, this is from Anonymous, and I'm not 100% sure I understand this. So Anonymous, if we don't answer your question, just please let us know. What if the patient's serum potassium and phos are still too high, even when using these specific renal formulas, specifically referencing end-stage renal disease patients on dialysis?
What's fantastic about these products is you can titrate them. If your serum levels are still too high, you can give less and then supplement intentionally somewhere else if needed.
So Alicia, let's hypothetically say we're just on Rena-Step, we're in the hospital, and the potassium levels are still running high. You would never think of decanting our products, or would you start thinking, oh, I need to up the dialysis? Like, what do we do?
You bring up a really great point, Michelle. And balancing electrolytes in chronic kidney disease isn't just nutrition isn't the only way to do that. There's lots of tools in the toolbox and lots of different ways to approach doing that, and nutrition being one of them. So increasing dialysis would certainly be a way to get more electrolyte clearance. And I'd also like to highlight, in an acute care setting, it's appropriate to use these products as short-term sole source to get your electrolytes stabilized. And once you're stabilized, then introduce a complementary feed or formula to get your balance once you're in a stable place.
Great, thank you. Okay, this is a question we get a lot, so I'm going to go for it on this one. In the US, Rena-Start is approved for greater than 1 year, but I often need to use it in infants less than 1 year. I've noticed that international VitaFlow materials suggest that it can be safely used in infants. Do you have any experience using Rena-Start in infants? So I just have to say, Alicia and I cannot recommend using our products in less than 1 because that is off-label. However, I will tell you the reason for the age indication in the United States, and that is FDA has certain requirements for the manufacturing plants that make these formulas. So they're much more strict with what they measure. And that's really the reason for the age indication. We can certainly connect you with some other healthcare professionals out in the field. So if you reach out to us, we'd be more than happy to do that. Okay, this is from Anonymous. If you have a child who is on a mix of Rena-Step, Rena-Start with Suplena, would you recommend transitioning to 100% Rena-Step, Rena-Start? If not, what do you do if potassium and phos still remain elevated?
Yes, that would be my first recommend. That would be my first move, would be to transition to more of the Rena-Start and Rena-Step, which are going to provide less potassium and phosphorus. So that would be my first step.
Yeah.
Yeah.
Yeah, it's important to go and look at the differences in the product, the nutrient content, because it's actually a little surprising. And then we really, really recommend age-appropriate formulas. So our products are the first and only pediatric kidney disease products in the United States. Okay. Okay, this is an interesting question. And Jessica, I'd like to invite you to answer as well. Do you have any thoughts on the use of potassium binders with older children taken once a day?
Yeah, I think when we have a lot of our teenagers that are really struggling with diet restrictions, even when they're not on formula, we do try to do like diet education, but at some point you just have to be like, okay, we need to get these levels down.
Yeah.
So most of my doctors are doing like either Kexate or Lacalma, like Monday, Wednesday, Friday and see how that goes, and checking labs, and then kind of seeing if they need every day or less.
Interesting.
So that's kind of been our practice here with our older kids that are struggling with low potassium diet.
I think that the Pediatric Nutrition Task Force's recommendations, that step-by-step approach, becomes really helpful in those situations, because you're looking at, all the other things that could be causing hyperkalemia, like are they constipated? And then as a very last resort, going to a binder. So in situations like that, it might be a helpful tool to kind of go through that process as well.
Yeah, like medications, and like if
Right.
all else is, you've tried everything else and you're still running high, we have done that.
Okay, this is going to be for Alicia. If the formulas are nutritionally incomplete, can you still use them if a patient receives 100% of their nutrition enterally?
Yes is my answer. I don't know. So yes is my answer, and because you can intentionally then supplement. VitaFlow has the nice DRI calculators that if you are for a time utilizing it as sole source, you can see where you're at and then supplement intentionally if needed.
Yeah, so we say a lot about sole source nutrition. It's in all of our materials. We're very, very careful about that. And why we're doing that, we're concerned that someone could go home and be in the outpatient setting, not have their labs checked as frequently as you would in acute care, and then something like the potassium goes low. So that's pretty much why we're so strict with our messaging. But if you go and you run our products through our DRI calculators, I mean, zinc, it's all there. These micronutrients, it's just the purposefully renal specific micronutrients that we've manipulated. So again, in the hospital, you're checking labs pretty frequently. When you go home, that's when you want to make sure they're getting something else, whether it's from the diet or another formula. Okay. Oh, someone did actually ask about calculators. So do you have any recommendations on a formula calculator to use for tailoring formula? Alicia said we have ours on VitaFlow Via. So if you're not a member, please join. We are also going to update them for the new formulation. So that's coming. But what they don't do is mix with other formulas. So our friend Nani Polderman has created online calculators, and she is very generous about sharing these. So if anyone's interested in a free calculator that looks at our formula as well as the other formulas out there, including just standard pediatric, just reach out to us and we'll hook you up with Nani. Okay, Alicia, how did you address Renastep being nutritionally incomplete? I was under the impression that it must be supplemented with other formulas. We've kind of said this, but just give me a one-liner.
It's purposefully incomplete. It's appropriate for short-term sole source, and when you're doing that, monitor closely and supplement intentionally as needed.
A build on that is when you're titrating, is there any kind of maximum ratio you need with our renal products and another pediatric, or is it patient specific?
My approach was always patient specific.
Okay.
CKD is a range, and the patient changes pretty dynamically. So I really felt like a tailorized individual approach produced the best outcomes.
Yeah.
Okay, this is a little bit of a tricky question. I'm going to roll with it. How much potassium is in the decanted formula? How do you calculate?
And Jessamine answered it. You don't. We have our best guesses here, and we see in the literature that if you're decanting with SPS or Butaramir, it decreases the potassium content, but there's a range in how much it decreases.
Yeah.
Great. Oh, this one's for Jessamine. Jessamine, was GR ever started on growth hormone?
No, but he probably should.
Oh.
But you did the first step of what
Yeah,
you
which
would
is-
do, because you wouldn't even think about growth hormone if you didn't first make sure he was getting enough calories. So now it's possibly an option, whereas before it may not have been.
Yeah, we definitely have switched a lot of kids into like the Rena Start, Rena Step and gotten them better nutritionally and then put them on growth hormone. And it's been great.
People are asking where they can get the Rena Step, Rena Start DRI calculators. And the answer to that is our VitaFlow USA site has a dedicated section, and it's called VIA, for healthcare professionals. You sign up, and then you'll see little tabs. One of them is pediatric kidney disease. If you click on that, you can see our recorded webinars, you can see our tools, and that's where you would be able to get those calculators. Okay, we are pretty much getting on time here, but we still have a bunch of questions, so I'm going to take one or two more. When you're talking about supplementation, are you referring to vitamins and minerals or supplementing with another formula?
Either or both?
Both, yeah.
It could be either.
Yeah, either or both.
Yeah.
Okay. We kind of talked about this, but I just think it's such an important topic that people keep having questions about. How long inpatient do you recommend trialing the plan from sole source to a feeding plan of Rena Step Start and another formula? So this is inpatient.
A few days at least. Get some labs and make sure everything is stable before going home.
Okay.
At least.
Yeah, that's the money shot, the going home. Okay. Let me just look. I think that we have answered most of the questions here. Oh, okay, wait, I do have a new one. This is from Julie. Do you typically add a calcium supplement? I find Rena Start, especially Rena Step, do not offer enough calcium for some patients.
Yeah.
Yes.
Yeah.
It's patient specific, but agreed. It's
Yeah.
purposefully low or in calcium, as we know that patients are possibly getting calcium from other exogenous sources, and that the recommendations for calcium are dependent upon the patient. So I agree, it's purposely lower, and that is something that you may supplement more often when utilizing Rena Start and Rena Step.
Yeah. I usually look at the calculator and see how much I'm giving, and if I'm giving like very low, it's time to talk. And levels are normal and not crazy high. Usually a conversation with a doctor, like, should we start some supplements, like calcium supplements?
Great. Okay, I think we've kind of gone through most of the questions. So I do want to thank our presenters. I want to thank the audience for your participation. We have a survey on the left. If you could please fill that out for us. It really helps VitaFlow to create new programs. We're also asking for feedback on new topics, so we love to hear that. You'll also get this as an email after the program. And then I am going to send everyone who has attended an email that contains my email address. I'm still getting some questions on where to get the DRI calculator, how to get in touch with Nani, so I will take those up as a follow-up. And then if you look in the question and answer pane right now, we do have the link to VitaFlow USA. You can go to VIA. You can then go to Pediatric Kidney Disease and go to the calculator. But I will also be following up with people if you reach out to me with my email address. Thank you. I hope everyone has a wonderful day. I hope you're having the beautiful spring weather we are in the Philadelphia, New York City area, and we look forward to seeing you again soon. Thank you.
Thank you.
Thanks so much.
Thank you.
Bye.